Hello everyone, this is Dr. Charles back with another Collidescope case from Arcana Laboratories. Today our patient is a woman in her 80s who presents with acute on chronic kidney disease, serum creatinine up to 7.7 milligrams per deciliter. By light microscopic evaluation here on the H&E stain, we could see acute tubular injury and there's patchy interstitial edema, and then we could see occasional tubular crystals. Again, here on higher power, we could see acute tubular injury, and we could tell there's acute tubular injury by cytoplasmic thinning, occasional vacuolization. Again, here we could see another luminal crystal. Here in a PAS stain, we could see that glomeruli are unremarkable. Here now in H&E stain, zooming in on these tubular crystals, we see that they are translucent to slightly basophilic. The tubular crystals occasionally incite a granulomatous response. Here we could see that the crystals are strongly birefringent under polarized light. And here on low power, we could see numerous polarizable calcium oxalate crystals. On silver stain, we could see that these tubular crystals are clear. Compared to the crystals that we see in this biopsy, they're clear to slightly basophilic. Here's an example of calcium phosphate crystals, which are strongly basophilic and more blue. Another separate disease that can also produce a crystalline nephropathy is 2,8-dihydroxyadenine, which is a rare and autosomal recessive disorder causing complete deficiency of adenine phosphoribosyltransferase transferase. DHA crystals, like calcium oxalate, are strongly birefringent under polarized light, as we can see in this figure. However, in contrast to the calcium oxalate that we saw in this biopsy, DHA crystals typically are brown on H&E stains, and they're silver positive. So in this case, we have an oxalate nephropathy, and here are the leading causes for oxalate nephropathy. Most commonly, we have enteric hyperoxaluria, where things like gastric bypass or inflammatory bowel disease, short bowel syndrome, chronic pancreatitis can lead to increased enteric absorption of oxalate. In 23% of the cases, we could see patients with excessive dietary intake of oxalate, abnormal diets including rhubarb, starfruit, cashews, and things like spinach or vitamin C. These are all high in oxalate and can produce an oxalate nephropathy. 17% of the cases are idiopathic. There's no explanation. Less commonly, iatrogenic medications like EDTA and certain antibiotics can cause an oxalate nephropathy. And then rarely ethylene glycol poisoning can cause an oxalate nephropathy. The least common causes of oxalate nephropathy are genetic or what's called primary hyperoxaluria. Here we could see the toluidine blue stained section for the same case, and the toluidine blue is usually used for electron microscopy processing. Here we could see an artery on this tall blue. The lumen is filled by this needle-shaped crystal embolus, or otherwise known as a cholesterol embolus. So in addition to the calcium oxalate, this patient also has renal atheroembolic disease, which is a vascular disease caused by embolization of dislodged components of atheromatous plaques. There often is a precipitating cause, including vascular procedure, abdominal aortic aneurysm repairs, cardiopulmonary resuscitation, anticoagulant therapy, trauma, or in some cases just spontaneous. The presentation for renal atheroembolic disease can be acute or chronic kidney disease. So in this case, it is important for the nephrologist to try and find an etiology to both the oxalate nephropathy and atheroembolic disease. Thank you for joining in for another collision case at Arcana Laboratories, and see you all next time.